Jesus Christ. That is the most unsafe IM injection I have ever seen. Hello, welcome back to the channel. My name's Ed, your friendly neighborhood emergency doctor, and this is Doctor Reacts to episode 4 of The Pitt. A huge thank you to Saily for sponsoring this video. More about them later, but let's dive in to The Pitt.
How long will you live without the oxygen?
It's difficult to say. Once the tube comes out, it could be anywhere from 30 minutes to several hours.
So this is a question that, we nearly almost always get asked when a patient is end of life. And it's so difficult to give an accurate estimate of how long someone's got left to live. I usually just answer whether we're dealing with minutes, hours, days, or sometimes even weeks. Having worked in a hospice as part of my training, it's really only seeing the rate at which a patient deteriorates that clues you into how long it's likely to be. And of course, it's medicine, so everyone follows their own course. I remember one chap who was sort of like Lazarus that I was looking after at the end of his life, and he was unconscious for a few days, what we thought would be his last few days. He then regained consciousness and became stable enough for us to transfer him home, where he had a hospital bed at home, and he lived for several weeks with hospice care in the community. This patient here has sepsis and pneumonia, so we're probably looking at hours for this chap.
I mean, this is happening, like now, like today. We just decided that Dad is gonna die in this room.
Oof. So firstly, thank you to The Pitt for showing this very real reaction. Although most people's reaction to grief is generally, at least in this situation, more understanding and less resistant to what's in the best interest of the patient. But we can all empathize with the daughter. There is no right way of feeling things, and it is good that she is expressing her concerns. An experience I want to share with you is, as a medical student, I had a seminar with 10 or so other students, and the doctor running the session, an excellent guy, Dr. Guthrie, asked us all to write down the worst thing that we think could happen to us. People wrote things such as starvation, complete paralysis, dementia, but nobody wrote death. Everyone wrote things that had a kind of thread of suffering or torture with no hope of recovery. And it just highlighted the whole point of the session to show there are things worse than death. And so for a doctor, our job is not to prevent death at all costs. It's a natural part of life. And sometimes it's our job to recognize that and to make the death as comfortable as possible for the patient.
Your father's dying, and you're choosing to allow that to occur naturally, rather than subject him to a torturous amount of procedures which would only delay the inevitable.
Yeah, very good. A brilliantly done scene.
What's the good news?
Ear canal is numb. Simple flush with saline will fix the problem.
You've got a dead bug in your ear. Cockroach.
I love this. Saline flush works a treat for everything from cockroaches to Lego bricks. That's probably a new fear unlocked for many of you watching this. My next holiday is coming up. I'm off to travel around Sri Lanka. Any recommendations, then hit me up. One thing I don't need to worry about is racking up a huge mobile data bill, and it can be the same for you on your next trip, thanks to the sponsor of today's video, Saily. I'm going to be traveling around, so relying on my phone for maps, transport links, Googling recommendations, staying in touch with friends, and replying to my lovely YouTube community. Looking up how much this will cost me on my phone contract is crazy. So around $60 for 1 gig of data. Comparing this to Saily, I can get 5 gigabytes of data for less than $12. The way Saily works is super simple too, as it's an eSIM, so it's all digital. You don't have to put anything in your phone. So let me show you on my phone. First, you just download the app, which is on iOS and Android. Select the country you are traveling to. I'm off to Sri Lanka. and then the plan you want. Also, you can get an extra 15% discount. You can use my code here, Dr. Hope, so let's put that in. You do need a phone that's compatible with eSIMs, although they offer a full refund if you purchase and find out your phone isn't compatible, and you are away. And that is all sorted, and it's just the one app that will cover you for over 200 places around the world, and it comes with 24/7 chat support. So download the Saily app or go to saily.com/Dr. Hope. You can use the link or the discount code Dr. Hope to get that 15% off. Thanks again to Saily for sponsoring this video.
A speaker tower came down on him. Looks like multiple rib fractures. Pulse 110, BP 130 over 85, decent stats at 96, 50 of fent in the field. Got it?
Left-sided chest trauma. The patient's slightly tachycardic, so it could be the pain, but you have to assume it's bleeding in trauma until proven otherwise. He's got decent sats at 96%, but he's on oxygen, so you really need to know if that's off oxygen or on oxygen, and if so, how much oxygen. And he's got rib fractures, so on their own, not really a problem. It's really if they've done any damage to the lung or even the spleen in this case underneath. So he'll be heading for a CT scan.
Isolated chest trauma with obvious flail chest, no human pneumo on POCUS, good stats and vitals.
Excellent presentation.
And we find out he's got a flail chest. This is a pretty significant injury. Although the exact definition changes, a flail chest is where you have trauma causing multiple adjacent rib fractures where the ribs are also fractured in 2 or more places. Our lungs are able to inflate because of the solid physical structure of the chest wall. So if we have a flail segment, essentially a few ribs broken in 2 places, they are no longer attached in any meaningful way to the rest of the rib cage. So when we breathe in, the low pressure sucks the flail segment into the chest, preventing the lung from inflating.
Sir, I'm Dr. Garcia from surgery.
I need surgery?
Not necessarily. No blood in the belly on fast.
Okay, you got this?
Yeah, this is very interesting point. And again, they've done their homework because this is a really important thing to communicate. Lots of conditions are looked after by the surgical team because surgery may be one of the treatment options, but that doesn't necessarily mean that people are going to have surgery. For example, if someone has an infection of the gallbladder, so cholecystitis, then most people do not need surgery. Antibiotics usually clears it up. However, if the infection gets really bad and the gallbladder perforates, so splits open, then they need emergency surgery. So that's why they go under the surgeons. And so if you say to a patient, oh, we're referring you to surgery, that could easily make them think that they're suddenly going to be rushed in for an operation. So it's good that they communicate this. Also, they mentioned there's no blood in the abdomen, which I really like. We've already diagnosed a flail segment, so you might get fixated on treating that and miss something else that's going on. I think all of us doctors have learned the hard way on that one. So as they're doing, we still need to rule out other injuries. A negative FAST scan, so a bedside ultrasound, doesn't completely rule out a splenic injury that we mentioned before. We still need a CT scan, but it's at least a reassuring finding.
Abdomen's benign. CT chest, abdomen, pelvis with contrast. Would you trust way more than your ultrasound skills?
Oh, that is a little bit harsh because actually no one's ultrasound skills would be as good as a CT scan, exactly as we alluded to before. A FAST scan, so a bedside emergency ultrasound, is a rule-in test. So basically only useful if you find an abnormality. It should not be used in isolation to rule something out. And that's because a FAST scan may miss fluid like blood in the abdomen if less than 500 mils, and certainly is nowhere near as good at looking at organ or blood vessel damage when compared to a contrast CT.
The festival.
We'll block all the nerves going to the broken ribs. Roll to the right. You'll be awake and pain-free.
Yeah, okay, so this is one thing that medical shows can be guilty of setting unrealistic expectations. The speed of care here is pretty impressive, but also not very realistic. Obviously, it's because it's a TV show and they want to keep it interesting rather than an hour of dull TV while we wait for the CT with us doing like regular obs and writing our notes. No one wants to see that. But yeah, in this scenario, he's getting a nerve block within seconds to minutes of coming in, which just wouldn't happen. Yes, pain relief is important. Some IV opiates should do the trick. In reality, though, he's stable, so we'd want to get that CT scan, then we'd have more of an idea of what's going on, then we'd be able to get everything prepped and to put in the nerve block in a more controlled manner if it's still indicated. Yes. This is something I think a lot of new doctors struggle with. Looking after yourself on a shift, because at any one point, someone's health seems much more important than you going to the toilet, for example. And it happened a lot to me too. During my first on-call shifts, I'd sometimes not eat, drink, or even wee for like 12 and a half hours, which is clearly so stupid. But at any one point, I just felt like that sick patient was much more important than me, having something to eat. But clearly over time, that is just not sustainable. So you have to learn to be able to take your breaks. And the emergency departments I've worked in take this very seriously, to the point where we frequently get asked by seniors if we've had our break or if we need a break. So that's really good. Dr. Robbie should be old and wise enough to be able to prioritize putting on his own oxygen mask before helping others with theirs.
Sats are down to 85 on 5 liters.
His lung contusions need some help. Start BiPAP, 10/5. That'll open up the bruised parts of your lung.
Okay, that is a very dangerous plan. So I think we're probably going to see that pneumothorax grow a little bit. So pneumothorax, an air leak into the pleural space, so between the lung and the chest wall. By having positive pressure when they're breathing, it's going to force more air into that space and so make the pneumothorax worse. You could put the patient on BiPAP if you have a chest tube in for the pneumothorax, so that's a way for the air to get released out of the pleural space. But just on its own here, I feel like we're going to see this patient deteriorate a little bit quite soon.
Came in an hour after the chest pain. If it's a heart attack, it can take more time for the heart damage to show up in the blood. Put your finger on that. Even with the normal EKG.
Yeah, nice little bit of medical science there. So we talked in the last episode about heart attacks, what we call myocardial infarction. So death of part of the heart muscle due to a blockage in the blood supply to the heart, so one of the coronary arteries. And we also said heart attacks are a spectrum. So if it's just a small blood vessel that's blocked, then just a small part of the muscle will die. But if it's a main coronary artery, you can die instantly. That's kind of what you typically see on TV shows, although in reality, these are thankfully less common. And if it's only a small blockage, we might only see subtle or indeed no ECG changes. And that's why this blood test is so important. When part of your heart muscle is denied blood supply, it doesn't just die instantly. As you know, with any part of your body, if you cut off the circulation, at first you won't really have an issue, but the longer you leave it, the more painful it's going to get. Although the heart is a very metabolic organ, it requires lots of oxygen, lots of energy. So a blockage, even for a small amount of time, is not what you want. If the heart muscle cells don't get any oxygen, they begin to become ischemic. And that's what causes the pain. And if this ischemia continues, you'll reach a point where you get irreversible cell death. So the cell can't function anymore and it can't maintain its cell membrane. So at one point, the cell membrane will break down and release the cell's contents into the blood. One of the enzymes that's specific to heart muscle cells is something called troponin, and that's what's released into the blood that we then measure to see if a patient's had a heart attack. So if we want to rule out a heart attack in someone with a normal ECG like we see here, the first troponin may be normal. So we need to give it enough time for those heart muscle cells, if they have died, to fully break down and release their contents into the blood. This is usually a few hours, but there are different protocols based on the sensitivity of the tests that each hospital has access to.
Thank you. All right, let's get you back to the waiting room.
What? No.
Yeah.
No, all I've been doing is waiting. I'm supposed to see a doctor now.
Yeah, we frequently may need a few interactions with a patient during a visit to the emergency department. What patients can miss is that a lot happens behind the scenes. So a doctor would have reviewed the patient's ECG and would have requested the troponin. But yeah, from this patient's point of view, they've just been sat there and nothing's happening, which is clearly not the case.
It's good to laugh.
Laughing our way into being a third world country. Remind you of home?
Oh, what the fuck? This should be escalated immediately to the nurse and doctor in charge. We can empathize that the patient is unwell and doesn't want to wait, but insulting staff, particularly racist abuse, there is zero tolerance on. It's nowhere near as bad as racist abuse, but I can think of 2 occasions where patients were, more than rude to me, basically verbally abusive. Both were extremely upsetting and, affected me for the whole shift. On both of these occasions, the patients were kicked out of the hospital. And on one of these occasions, the patient's partner was actually filming it on their phone and threatening to go to the newspapers. And the doctor in charge grabbed the phone, deleted the video, which I'm not sure the legality of. But yeah, they were kicked out and banned from the hospital. I didn't even know we could ban people from a hospital.
I was showing a colleague how to polish it and the neck broke. Not my finest.
Did it shatter?
No, it cracked cleanly in 2, but as a reflex, I jerked my arm back.
Yeah, you've probably worked this out already, but the reason why they're interested in what's caused the injury and whether the glass shattered was whether there's any debris left in the wound and if it's a dirty wound. So could there be a possibility that the patient needs some tetanus prophylaxis? With the history of a glass shard, you'd still want to get an x-ray before closing the wound to exclude a small fragment, even though we heard the glass didn't shatter. It's just not worth the risk of having a foreign body in there and therefore a source of infection.
Toxic to 78, BP's crashing, systolics 82.
Pulse is thready. I should intubate. Does he need a massive transfusion protocol?
No. Absent breath sounds on the left. Tracheal deviation to the right. 14.
Exactly. So absent breath sounds on the left with tracheal deviation in a patient with chest trauma that's got a no pneumothorax on BiPAP. We've already called it. What do you guys think's going on? Yeah, exactly. We called it a tension pneumothorax. So air is going into the lungs and through the leak in the lung into the pleural space, the space between the lung and the chest wall. And this air keeps expanding and eventually squashing the heart and blood vessels without urgent intervention. So a large bore needle under the armpit to decompress the air. The patient will arrest very quickly. Because of this very visual life-saving treatment of a needle in the chest, this is one of those medical issues you see a lot in TV shows. I think it was in the first episode of The Good Doctor, and it was in the last episode of House I covered too, but I've actually never seen it in my practice, thankfully.
Tension pneumothorax from the BiPAP's positive pressure. You hear that?
Yeah, and we hear the hiss. Very good. Yeah, and thankfully this tells us he's done the right thing. Although imagine doing it and not hearing the hiss and just realizing you've stabbed a patient incorrectly. I'm sure that's happened, and that's why we need to be confident in our examination and recognizing these things. He's done the needle decompression here in the second intercostal space in the mid-clavicular line, which is fine. That's how we used to do it. I don't think you'd get in any trouble for this, but the current ATLS guideline is we go in the 5th intercostal space, so lower down and just in front of the mid-axillary line, so just in front of the middle of the armpit. And the guideline changed because there tends to be less distance to go into the pleural space, so more likely to be successful. And just a bit of a recap of the anatomy we learned in the last episode. Whenever we go into an intercostal space, we go just above the rib. The reason being is that the blood vessels and nerve supply are actually tucked just below the rib, so we want to reduce the risk of damaging them.
Who the hell ordered BiPAP, Garcia?
No, his stats were down. I did.
You did. Without running it by me.
Can I put in a test tube?
Wow, Dr. Santos has some serious confidence. She's maybe overcompensating because after making an error like that, you want some kind of acknowledgement what you've done and some kind of apology. I worked as a teaching fellow for 3 years, so training medical students to become doctors. And it was these attitudes that worried me the most, the overconfident students, never the ones who were sort of overly conscientious.
You go right up the middle. In zone, baby.
Okay, yeah, got it.
Okay, Mr. Krakosia, we're here to help you. We're here to help you, sir. Oh, God. What do I do? No.
Oh, my God. Whittaker's first day from hell continues. I'm probably a bit late to the party here, but I get it now. He's the character that all the crap is going to happen to. Jesus Christ. That is the most unsafe IM injection I have ever seen. Waving his arm around. It could have gone anywhere. It could easily have gone into one of his colleagues who should be doing a better job of restraining the patient. Maybe have 2 people on the limb that he's going to be injecting in. Secondly, that medication worked way too quickly. With the pain of being stabbed, the patient will be potentially more aggressive for several minutes until that midazolam kicks in. But yeah, poor Whitaker. I mean, he's already changed his scrubs, right? And now he's got piss on them too. This is why when I see emergency doctors with fancy trainers on, I'm always like, they ain't gonna last long. So right at the end of the episode here, we see Dr. Robbie confirming a death. We usually don't do this straight away, like as soon as they've passed, like we see here. I tend to wait 30 minutes or so, particularly if the family are there, to give them a moment. And I usually ask the family to leave because although we're only checking the pupils, the pulse, the heart sounds and breathing, you do have to examine for 5 minutes. And so it can be a difficult thing for family members to witness, considering their relatives has just died and then you're doing something very clinical. Also, a kind of funny, sad story is that one of my colleagues said that when they worked on-call shift, they were asked to see a patient who was in their last few days, and the nurse had said they'd died and to come and confirm the death. He reviewed the patient and confirmed they were dead. Although a few hours later, he was bleeped by the nurse and was told the patient was now breathing again. So yeah, did not do a very thorough job confirming the patient had died. Although sadly, the patient ended up dying later that day, but that story always struck me as being a bit weird and to remind us all that we should do everything very thoroughly. Oh, Robbie, you are also in danger of declaring this patient dead when they might not be. Why? Because he's got his stethoscope in his ears the wrong way round. And when they're in like this, you can't hear anything. I've spotted this in a few TV shows now. I think the last time I saw it was in Scrubs. And it's because we all did this when we first got a stethoscope. Let me find mine and show you why. I think it's counterintuitive because you think you want the earpieces facing back because your ears are sort of behind your face. But when you think about it, that's not the best way to put something into your ear because you have the tragus here. You want to go from the back to the front. You know, that's the way you put in AirPods, for example. So yeah, you want to have the earpieces facing out. So when you open them, they face forward and nestle in to your ears like this. Still alive. So there you have it. Another great episode. Really enjoyed the medical cases in this one. You know, if they wanted to make it 100% realistic, they clearly could, but I feel like they've used a creative license to make it a bit more dramatic by showing things happening quicker than they usually would, and also showing more extreme cases. For example, the patient developing a tension pneumothorax. You know, all of these just make the show much more enjoyable. I always say this, but I love reading your comments, so please let me know your thoughts on this reaction and this episode in general. Thank you again for all the support on the channel. If you've got this far, then please give this video a like and consider subscribing too. A huge thank you to Saily for sponsoring this video. Do check them out if you have any plans to travel abroad anytime soon. I've been hit with a bunch of copyright claims on my videos lately, and so without these sponsors, I wouldn't be able to make these videos. So again, a huge thank you to Saily. I hope you're all well, and I'll be back soon.